everyone. Good evening. Thank you so much for joining us here for the 90-minute webinar, which we have scheduled tonight. We're going to be engaging in a educational and community-based discussion hosted by Center for Medicine Assisted Therapy and in collaboration with Psychedelic Lived Experiences and Pedram Dara. We are really excited to be hosting our first official webinar together and also as part of CMAT. And we just really want to acknowledge and thank you for taking the time to be joining us here today. And we look forward to continuing to join in engaging in educational conversations like this in the future. And so this is just the beginning. We've got an evening full of enriching conversations to have, and we will be allocating a lot of spacious time for Q&A so that there will be the opportunity for people to be able to share questions, insights, and thoughts that they may have in learning more about this topic that we are all very passionate about. And just a quick minute to just do some introductions. So my name is Shoshana Ward. I'm joining today from Vancouver, British Columbia, as well as Dr. Devin Christie, also joining from Vancouver. And then we've got Pedram here, who's joining from Ontario. And so a little bit about myself. I am the co-founder of CMAT along with Dr. Devin Christie. We are extremely passionate and excited to be bringing forward this work that we hold very near and dear to our hearts. And I am the clinic and community director at Center for Medicine Assisted Therapy, pardon me. And then Dr. Devin Christie, it has an extensive background in functional medicine, chronic pain, and psychedelic assisted therapy, and is the co-founder of CMAT and also the medical director, and also engaged very much in research and a variety of really meaningful projects to be shepherding this field forward. And so, yeah, thank you so much for being here. And then Pedram Dara, who is calling in this evening from Ontario. And so we're kind of bridging the East and West Coast on our call, but also in the spirit of this collaboration. And so Pedram was a participant in the MDMA clinical trials, and we'll be speaking a little bit more about that as the evening continues, and is also the founder of Psychedelic Lived Experiences, which also he will be speaking about and sharing some exciting things that are to come in the next couple of months, online offerings, which you can engage with to learn more in that way. So thank you for being here as well, Pedram.
And we're also really, really happy that Pedram is also our lived experience advisor with us here at CMAT. So really happy to be engaged and collaborating in that way.
Thank you. So tonight we're going to be, we've got 90 minutes allocated to be speaking about medicine-assisted therapy. We're going to be having a focus on PTSD and chronic pain. We're going to be talking about MDMA and ketamine-assisted therapy and some of the aspects to which this is approached within a clinical setting, with or without therapy, and why we think it's important to be able to include, protocols as part of the approach to client engagement in terms of having positive therapeutic outcomes and what that looks like. We're going to be basing that in research, and we're going to be sharing from our hearts and also from science. And so the wonderful thing that also not only bridges our interest for all three of us in this field is that we all also carry with our hearts the lived experience that has led us to leading in these spaces professionally. And we will be definitely sharing from those voices as well throughout the evening. And it's also part of what has brought us together in this very unique and inspiring collaboration in terms of really wanting to ensure that we're bringing voice to lived experiences. And so we hope tonight will be the start of that platform in terms of how engagement might look as we continue to carry that forward and shape that vision.
Amazing. Thank you so much, Shoshana. And I'm going to kick us off here. And as I do that, I also want to offer a land acknowledgement. Shoshana mentioned we're here, the two of us in Vancouver, British Columbia, which is the traditional and the ancestral territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. And we also acknowledge that people are likely calling in from many different places around the globe, and we honor those traditional Indigenous lands that from which you're all coming in, calling in from tonight. Also, I want to mention Shoshana and I, as well as being co-founders and our other roles here at CMAT, we're both also therapists with CMAT, providing trauma-informed somatic relational therapy and level one internal family systems lens as we work with medicine-assisted therapy for a number of different indications. Tonight, we're focusing on PTSD and trauma itself, which I'll speak a little more, that not all trauma shows up as PTSD, and as well as chronic pain, which has also been my focus as a medical doctor for basically the last 10 years of my career, as well as medicine assisted therapies and mental health. All right. So this is just a little overview of what we're talking about tonight. First, just very briefly touching on what is PTSD and chronic pain and the burden of suffering that both of these conditions really speak to around the globe and certainly here at home for us and in our community. And then we'll talk about medicines as tools for healing. Coming from a Western medical background, often we think of medicines as, that pill we take to solve a problem or prevent a symptom. And in medicine-assisted therapy, we're inviting you to think of medicines in a bit of a different way, not as something that is to make something stop or dull something down, but as actually a tool for a deeper healing process that the therapy and all of the protocol around that supports. And why medicine assisted therapies, we believe, are important approaches to these conditions, among others, at this time. We'll review what that process looks like, at least with us here at CMAT. And then a little bit of an introduction to the two medicines we're focusing on tonight, MDMA and ketamine. And then we'll shift over into lived experience, and you'll hear from each of us, as Shoshana mentioned. And yeah, I'm really excited to hear more from Pedram on that as well. And then we'll wrap it up tonight with a little bit of information on accessing medicine-assisted therapy with us at CMAT. And then, as Shoshana mentioned, lots of time at the end for your questions and answers, which if you could, if they come up during the presentation, go ahead and throw them in the Q&A box. And we'll also have lots of space for you to raise your hand live when we're in the Q&A period at the end as well. So let's talk about PTSD and chronic pain. So first of all, PTSD, post-traumatic stress disorder. That's a disorder that's defined in Western medicine and psychology in a book called the Diagnostic and Statistical Manual, the DSM, or the DSM-5A is a current version. And so it's a label, it's a diagnosis that has specific criteria for people to meet. And it definitely is a diagnosis that when people meet those criteria, it certainly represents a lot of suffering. But I've put an iceberg image here on this slide because I often think of PTSD, that very discrete diagnosis as defined in the DSM, as kind of like the tip of the iceberg of trauma. Trauma symptoms can show up in many different ways that may not actually fit those narrow criteria. And they've put the criteria for PTSD here, which is re-experiencing avoidance, negative mood and thoughts, hyperarousal, and then there's a dissociative subtype. And I put shame and terror there. Those aren't the official criteria, but in negative mood and thoughts, it's pretty ubiquitous that shame is an aspect of the experience in PTSD in some way, shape, or form. And the criterion A, which is not on the slide, is that there's a threat to life, actual or potential, that is either experienced by that person or that person experiences vicariously. And it's really debilitating. With PTSD specifically, there's a lot of treatment resistance, which really means not fully responding to the currently available treatments, which in psychiatry really focus on SSRI medication. Those are the main approved medications for treating PTSD. But really, only 20 to 30% of people with PTSD fully recover with the SSRIs, other medications, as well as the other types of therapies for PTSD that exist out there, and there's many. Some of the evidence-based ones are EMDR or eye movement, desensitization and reprocessing therapy. There's something called exposure therapy and cognitive reprocessing therapy. These are all therapies that stand alone as treatments for PTSD, but there's very high dropout rates from these therapies because engaging in the therapeutic process involves confronting the trauma to reprocess and attempt to heal. And that can be a really, really challenging and difficult thing, if not impossible, for people who are suffering with PTSD. And for everyone that's under the surface here, not necessarily fitting the narrow criteria, trauma symptoms can show up in other sort of labeled conditions, such as panic disorder and depression and other things. It doesn't mean that when you have those diagnoses, that trauma isn't an aspect of what's underlying and potentially contributing to sort of how those symptoms are showing up to fulfill that criteria. Addiction, generally, often there's can be some trauma and many other forms. I'm not going to go into a big talk on trauma itself tonight, but just to recognize that it exists beyond the narrow criteria, and we do treat people at CMAT beyond the narrow criteria of PTSD. There's also something called complex PTSD, which also isn't specifically defined in the DSM, but represents sort of a multiple different forms of trauma together, including early relational developmental trauma, as well as often shock or incident trauma. So moving to chronic pain. So chronic pain is pain of duration more than 3 months that is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So chronic pain can exist even when there isn't ongoing tissue damage. So tissue damage and nociception, which is your pain fibers firing to your brain when you hurt yourself, is not necessarily the only thing that's happening in chronic pain. So chronic pain, there's a lot of complex things that happen. Chronic pain we can almost think of as a learned response in the brain. There's a lot of wiring that happens in the brain that sort of moves across these different parts of the brain, the sensory parts of the brain, the emotional and the fear associated parts of the brain as well. And so it's really complex, and it's not something that can be treated similarly to PTSD with a pill, for example, or one intervention very effectively. Chronic pain affects approximately 20% or 1 in 5 of adults. PTSD, it's about 11%, 1 in 10. And for chronic pain, there's a really high persistence year to year, as there is with PTSD. There can be really major functional impacts and disability associated, also something it shares in common with PTSD. And for pain, the common medical or surgical approaches, pharmaceutical approaches remain very limited. And it's established now internationally that a biopsychosocial approach is the gold standard of treatment for chronic pain, which means that treatment needs to address the psychological and the social impacts of having chronic pain and the ways in which chronic pain is this complex phenomenon happening across many different aspects of the brain that contribute to the pain experience. So now moving into medicine-assisted therapy, where we're thinking about medicines as tools for healing. So I'm going to explain a little bit about what medicine-assisted therapy is. It's really a combination treatment. So in Western medicine, we often think of the medicine itself as the treatment. But here in medicine-assisted therapy, we think of the medicine as a catalyst. So it's a potent catalyst or tool that combines with the overarching therapeutic process and also factors of the curated setting. So people may have heard the term set and setting, or the context in which the therapy is happening. That can include things like music that is offered. We'll talk a little more about that. And other factors, the presence of the therapist. All these factors are synergizing together as the treatment. So the medicine itself isn't the treatment. So if you hear out there, oh, MDMA is potentially a cure for PTSD, well, that's actually only partially even approaching the truth, right? There's research is still underway. Claims like cure are big claims that may be sensationalizing, and we like to say, it's the treatment that shows a lot of promise, but the MDMA itself isn't the treatment. It's the medicine that catalyzes and supports the treatment process, which is a really deep holding that requires a lot of skill and a lot of training. So therapists are specially trained to be able to facilitate this therapeutic process with people, which involves non-ordinary states of consciousness, people taking powerful psychoactive medicines. Today, we're talking about two of them, MDMA and ketamine. And the way we approach medicine assisted therapy is that it's intended as a brief, intensive therapeutic intervention. So you can think of a lot of conditions, mental health conditions that we treat like as though they're psychological injuries, right? Things have happened, and we want to actually provide an intensive intervention that I've often used the analogy of like a surgical process, right? Like it has a start, it has a middle, it has an end, it has recovery and integration, which I'm going to share about in a moment. But it's an intensive process that we want to make sure people are ready for, prepared for, very well prepared for, and that we can hold them through. And then I think another thing that really distinguishes how we think about medicines as tools for healing, the medicine is not the healing. We see the person seeking care, as the source of their own healing. Healing is happening within them. And the therapy that is offered and the medicines that support that therapeutic process are all supporting a healing process that is indigenous to that person, that is part of what is in their nature, right? We all have it in our nature to heal. All you have to do is cut yourself and you see the wound heals, right? So we can support that process. We can provide optimal conditions. And that's really what we're trying to do here to our best in medicine assisted therapy. So we really think these therapies need to be considered and brought forward and made accessible because there is a significant amount of research backing their evidence. And there's the conditions, particularly the ones we're talking about today, are, as I said earlier, are really a huge burden of suffering, right? Chronic pain and trauma. They can devastate people's lives. They can render people unable to work. It can really interfere with relationships and family life. And one of the most common things I hear from the people I work with trauma in terms of their goals is, I want to feel alive again, right? Not even feeling alive to their lives. So these are serious conditions that many, and if not most, have exhausted all of the existing treatment options. So we're at CMAT really taking the experience we have from engagement in this research and bringing that into clinical practice with best practice standards that are really coming from that research-driven experience. There's really promising research mechanisms of action as well for the medicine-assisted therapy approach for both of these conditions we're talking about today. And also, it's not the first time that medicine and therapy are paired. In fact, in a slightly different way, not in such an acute and intensive way, but for depression, a very common condition, the gold standard is for people to engage in cognitive behavioral therapy while also taking an SSRI. And for smoking cessation, it's also the gold standard to recommend counseling or CBT while also taking a medication designed to support smoking cessation. So those are pills you take every day, whereas the medicines we're working with here are profoundly psychoactive and you only take them on a few occasions in the process of therapy. But there is an overlap here in sort of this way that medicines and therapies can synergize and are part of current best practices for other conditions. So here's the MAT process at a glance. At the start, we want to make sure that people are suitable for the treatment. So also making sure that there is a diagnosis there, something that we have evidence base to support the treatment of this condition. We also want to rule out medical conditions or psychological conditions that could render medicine-assisted therapy unsafe for an individual. So those are things like maybe if there's unstable heart disease or liver failure or other things where a person couldn't metabolize or take a drug safely that we're offering. And also some of the psychological contraindications. Just a few examples are, very acute and severe suicidality is something that we would be concerned about. Active psychosis or recent history of psychosis, that's another thing, because we don't want people to become destabilized and by the treatment. The treatment itself, as I've mentioned, can be quite intensive, and it's a deep process that people enter that's brief, intensive, and we want to make sure people are going to be held in a good way, but are also coming in without these risk factors that might make it unsafe. So we check for that. We do a screening process with a medical doctor. We also assess environmental conditions. So does the person have stable housing? Are they living in stable environment, right? Or is there somebody that's being actively abusive in their environment? Or is their home unsafe? These might be things that are really a priority first before moving into this kind of process, which again, with those conditions present, could be destabilizing for an individual. Once people screen as suitable for the treatment, then we move into a phase of preparation. So this is done with a therapist where there are certain skills taught, goals and intentions are set, there's important safety agreements that are established and reviewed, and really all of the nuts and bolts of the set and setting to really optimize the person and their orientation to the process is established. And in this stage, we're also building therapeutic rapport and really learning more about that person's history and building therapeutic trust. Then, after several preparation sessions, as many as are necessary for the person to feel prepared and the therapist to feel that this person is well prepared, then we would move into the medicine session itself, which is depending on the medicine being used. With MDMA, that's a 6 to 8 hour day. And I will say right now, this is on an upcoming slide, that MDMA currently isn't an approved treatment by Health Canada on a widespread scale. It's only approved through a special access program for individuals that can demonstrate that they've tried everything else and therefore merit special access on a case by case basis to MDMA. So we do that process with people. Ketamine is much more widely accessible because it's a regulated medicine that we can prescribe here, don't need special authority from Health Canada, and it's a shorter acting medication. It's about 2.5 to 3 hours as a ketamine session, and the therapist is present, the very same therapist that prepared the client. They're the therapist throughout the arc of treatment. Music is offered, curated playlists, and other aspects of the setting to really optimize those medicine session days. And then after the medicine session, and usually the very next day, there's an integration session. And this is important because often the effects of the medicines, which both of these medicines enhance neuroplasticity, really can help a person to see things in a different way. We want to anchor that in that window of plasticity. We want to help them also continue to process what has come up. Often these medicine sessions can be profound, they can be difficult. So often continued therapy and emotional processing is part of integration and helping a person make meaning out of their experience, that they're making that meaning for themselves. And then to commit to behavior changes in alignment with the different values and meanings and insights that have come to them through the medicine experience. Now, depending on the medicine as well, there's an arrow here because generally after the initial integration, we would go back and do a second and often a third medicine session spaced with ketamine about a week apart from most conditions. With MDMA, we follow the protocol that MAPS used in the research on PTSD, which I was involved in as a therapist, and in that protocol, those MDMA sessions are spaced more further apart, so about 4 to 6 weeks apart. And then always concluding with integration, and that's kind of the process at a glance. So a little bit here about the medicines. So let's talk about ketamine first. Ketamine, I think gets a bad rap because I often hear people saying like, isn't that horse tranquilizer? It's the most common thing I hear people say. And somehow that got shared around as like a meme. And really, ketamine was developed first for human beings, not for veterinary medicine. It was developed in the 70s, and it became actually a very important medicine during the Vietnam War. It was known as the buddy drug because ketamine is an anesthetic, and ketamine can be used safely as an anesthetic to completely anesthetize someone, and they will maintain their own airway. They don't need to be on a respirator machine with a tube down their throat. So, getting buddies off of the battlefield safely, they would carry this in their pocket, inject it, and help them get to the medic tent. This was one of the very first applications of ketamine. And as you can imagine, in developing countries around the world where access to sophisticated surgical equipment and respirators can be limited, the World Health Organization has called ketamine one of the very important drugs. Because of its safety profile and its ability to provide anesthesia while a person maintains their own airway. So in the application for chronic pain and PTSD, we don't use ketamine at anesthetic doses, though. We use it at lower doses. What ketamine is, for any of you chemists out there, we've got the chemical structure here, and it works on the N-methyl D-aspartate or NMDA receptor in the brain. That's one of the ways that we've discovered that it acts, and there may be other ways. I'm sure there are, but it's one of the commonly known mechanisms on that receptor, blocking it, and it can cause, as we've learned from research, rapid antidepressant effects. For about 70% of people, rapid antidepressant effects within a 24-hour period that can last on average about 7 to 9 days. So there is a model out there for depression in clinics where people get ketamine infusions 1 to 2 weeks or further apart. That's again just using it as a medicine by itself. But it's also an analgesic, so it reduces pain. It's often used in the surgical setting towards the end of orthopedic surgeries to help to reduce post-operative pain in people and reduce the need for opiate and other medications. Ketamine also has powerful dissociative properties. So in those sub-anesthetic doses, when you are still aware that you're you and you're here and you're awake, but in an altered state, people can feel a bit of floatiness or disconnection from the physical body and other different psychedelic effects that a person can experience. And in medicine-assisted therapy, we're getting people into that zone, not an anesthetic zone where they wouldn't really remember what happened, but into more of this trance-like zone. So it's delivered through different modes, under the tongue and absorbed in the mouth, through the nose with a spray intranasally, and also IM or intramuscularly with an injection. And we use all of these 3 different modes of delivery at CMAT. And it can be helpful in reducing avoidance. So one of the problems that conditions like PTSD and chronic pain that they persist is that there's a very natural and understandable defensive avoidance. And under the effects of ketamine, it can make it easier to approach the experience, different experiences associated with trauma or pain, support emotional processing, and as I mentioned earlier, also enhance neuroplasticity, which can really support learning and therapeutic change. Now, MDMA is a different kind of medicine. It's also potently psychoactive. It's known as an empathogen. So, empathogen is like bringing emotion and empathy, the word empathy, opening one up to their emotional experience. It increases the amount of serotonin in the brain, as well as dopamine and norepinephrine. It also increases oxytocin. You might know that as the bonding hormone. And MDMA is known to reduce the fear response, so the areas of the brain, particularly the amygdala, that respond to fear, and reduce negative thoughts. So under the effects of MDMA, negative thoughts and feelings tend to have lower valence, and positive associations and feelings tend to be more salient for people. So consequently, MDMA can really enhance therapeutic trust and self-compassion. This is all what has come from the published literature and reports and qualitative information, but you'll get to hear more about that live from Pedram when I hand it over to him a little later on. So MDMA is delivered by an oral capsule, And it is only delivered in the context of an extended therapist supported session with all of the preparation and integration on either side of that. As I mentioned, it's not yet regulated by Health Canada, but there is access through the special access programs for people with severe treatment resistant PTSD. So, a little bit about evidence. I don't want to get too nerdy here with numbers, but I think it's important to know that for treatment of PTSD with MDMA, there's actually quite robust evidence that comes from large phase three FDA drug approval clinical trials that have multiple sites around the globe. Each clinical trial for phase three involved over 100 participants. And the first was published in 2021. The second was published in 2023. And both of these studies showed the same thing, which was large reductions in the CAPS-5, which is a scale used to measure the symptoms of PTSD. So that was the primary treatment outcome being looked at for efficacy in these clinical trials was CAPS-5 score. And it was a larger reduction than the placebo arm. So you can see in the little image on the side here with the MAPS logo below. MAPS was the nonprofit organization that really started all of this and is really credited for how far this research has come to date. Before treatment, people in the studies, their CAPS scores were in the high 40s to 50, which is extremely high. People had had PTSD for on average 16 years. So this was long-term PTSD people coming into this study. And the lighter blue bar in the middle is the results for the people that received the placebo with the therapy. So they actually had quite a drop in symptoms still. So the therapy itself was quite effective. The therapy was two therapists, and it was 52 treatment hours of therapy total over the protocol. But when you look at all the data, you see an even further improvement with MDMA assisted therapy, the purple bar on the side, bringing the CAPS-5 scores into the 20 and below range, which generally is getting to the point where people may not even qualify anymore for the diagnosis of PTSD. Interesting to note that Australia has looked at this data and has gone ahead and approved MDMA already. And so we're still not approved in Canada, but we expect to get there. The US FDA has asked for some additional clinical data before they will approve this treatment, but it really is the most effective treatment for PTSD that we've seen in a very, very long time, if not the most effective. Actually, you can see here in the first bullet point, the effect size for any statisticians out there is 2.1. That is the very large, like extraordinarily large effect size for a treatment. Whereas Zoloft and Paxil, which are the SSRIs that are approved to treat PTSD, their effect sizes from the best clinical trials are only 0.37 and 0.56. Okay, how about ketamine for PTSD? Well, there is actually some good data out there as well for intravenous infusions of ketamine in a randomized controlled trial. This showed significant symptom reductions, again, using the CAPS-5 score versus placebo for chronic PTSD. And what this data showed is that effects can be rapid, but maybe transient without psychotherapy. And the current systematic reviews and meta-analyses of the literature to date suggest that ketamine is promising for PTSD, but especially so when paired with psychotherapy. So maybe not so much as the drug alone, but more in a medicine-assisted therapy context, like we do at CMAT. And the evidence for ketamine for chronic pain, as well as for psychotherapy alone, well, systematic reviews of IV ketamine show pain reductions in selected chronic pain conditions like neuropathic pain, complex regional pain syndrome, The durability of the effect will vary and different protocols differ across clinics, but IV ketamine has become a pretty mainstream treatment for chronic pain, certainly in the US and also here in Canada. I used to work at Change Pain Clinic here in Vancouver, and they have an ongoing IV ketamine program for pain, and people with all kinds of chronic pain get recommended to that program. So it is something that's widely offered. Now, psychotherapy alone for chronic pain is also a gold standard recommendation. There's enough evidence out there that it improves pain related function and quality of life, which are two things we're really, really interested in improving for people suffering with chronic pain. So, as I mentioned earlier, guidelines now recommend psychological therapies for chronic pain as a very crucial part of a holistic treatment plan. So, putting it all together, for chronic pain, the rationale for medicine assisted therapy is that psychotherapy is evidence based. It can build skills and assist behavior change and improve quality of life. And ketamine can also have pain reductions that may be shorter in duration and avoidance reductions and open this plasticity window. And together they can synergize. And as I mentioned, chronic pain is complex. It involves the brain being wired for pain, and we want to help soften and rewire so that chronic pain isn't the day-to-day experience, or if it is, it's reduced and the suffering is reduced. Emerging, yet to be published data of colleagues of mine in Toronto that I was just speaking with a few days ago, really exciting. They did a study looking at ketamine and psychotherapy combined for chronic neuropathic pain. And they did a placebo-controlled clinical trial, and they showed very, very strong response rate with the two treatments combined. So look forward to seeing this published in the coming months. I've written a white paper on our approach to chronic pain at CMAT. And so if you're interested in a deeper dive into sort of more the intricacies of our approach to chronic pain and how we understand it and help people learn about it, you could scan this QR code and just download this white paper and read it. And we would happily answer any questions. So we're going to shift to talking about lived experience now. This is enough data, I think. I'm sure there's a lot of questions generated by it, and but the data is only one thing, right? And in the different research that I've been involved in, it's really the personal experiences of people that I am most interested in, because that's where we hear the real stories, the stories of suffering, of triumph, of healing, of challenge, of compassion and growth and learning and the whole human experience. And that's really what I'm here for. And I'm sure what, certainly my colleagues at CMAT are here for is really touching real lives, as my own life has been touched in my own personal injuries and traumas and struggles over my own life. So we believe lived experience is critically important for informing how we determine what healthcare priorities we should have at a large public level, for informing how we're delivering therapies at the clinical level in a clinical setting like at CMAT, and also for informing research agendas and what is important to even research. Often that's limited to people in the ivory tower of academia. What about the people who are living their lives out there that this research is hopefully going to help improve? Lived experience, we believe, is really important for informing those agendas and where those dollars are going. There is so much to really put behind lived experience. And I'm going to, before I pass it to Pedram, who can share more about that and his own lived experience, I was going to share just a couple of my own anecdotes that relate to the topics today. In 2018, I actually suffered, unfortunately, a series of head injuries, one from a very intense ski accident, backcountry skiing, where I hit a tree. And then shortly thereafter, very shortly thereafter, I hit my head on a wall-mounted cabinet quite hard, and then was within a few weeks in a car accident that involved is quite a severe car accident. So consequently, I had a post-concussion syndrome, mild traumatic brain injury, as well as I can tell you the second that car accident happened, I felt like my capacity to hold myself together shattered. And I started to experience symptoms of PTSD, which I didn't really realize was PTSD until maybe a month into my recovery when I just kept startling awake and having nightmares and seeing phantom things flying at my head that didn't exist, all these different things. And I'm so, so grateful that one of my doctors was willing to prescribe sublingual ketamine for me because my colleagues in my, physicians for ketamine that I was already connected to because of my line of work and interest in this field all responded to me on a listserv that I should try it. I should definitely try it for both the PTSD and the head injury. And but it wasn't standard care yet. So I'm so grateful to that doctor who was willing to kind of stretch what they were comfortable with and let me responsibly take home these sublingual ketamine lozenges, which when I took them, and I didn't take them necessarily every day, but maybe 2 or 3 times a week, I felt like the frayed wires that had no insulation of my nerves under my skin that were buzzing incessantly and startling all the time settled. And like the nails on the chalkboard inside my skin settled, like these symptoms of PTSD that I have so much compassion for sufferers because it's like you just want it to turn off and it can't, it doesn't. And so taking ketamine in my own healing journey with both of those conditions provided me a lot of hope that I could get better as I felt this like transient relief. And also, I believe, contributed significantly to my healing. So that's a bit about my personal experience with ketamine and those conditions, PTSD being one of them. And my other lived experience I want to share is about being a therapist in the MAPS clinical trials for PTSD. I'm very grateful that I got to be a part of this really, really important work as a therapist. And I shared this with Pedram in my interview for the Lived Experience Summit, which he's going to talk about coming up. And it still brings tears to my eyes every time. It's just when I went and did my training to be an MDMA therapist for this clinical trial, it was quite an extensive training. We watched hours and hours of videos that were from the phase 2 clinical trials. So my teachers, Michael and Annie Mithofer, Marcella Ottalora, and others, we saw they were really the people bringing this therapeutic modality forward and watching them with these participants with severe PTSD and seeing clips from across the arc of their treatment, it transformed me. Like it made me realize that this is one of the most important treatments currently in the world because of the burden of suffering and PTSD and how PTSD can decimate lives. And to see the transformation, to witness it in these videos over the arc of the training was just so stunning and so beautiful to me that I decided I needed to dedicate my career energy to this. And then, of course, in my involvement with real people as a therapist in the study too, I really had such a deep appreciation for the intensity of the holding and the level of skill and the reasons why the protocol was put together the way it was with 2 therapists to hold a person through this. And I learned so much from my own practice and with so much humility also at seeing the incredible healing processes of the different individuals that I worked with and how they're so unique, but the similarities in the ways that MDMA helped in different but similar ways. So that's a little bit about my lived experience. And Pedram, I'm going to hand it over to you. And since I'm sharing the screen slides, please just let me know when you'd like me to advance the slide. Thank you so much.
Thank you, Devin. Hi, everyone. First of all, thanks for tuning in. And it's incredible to be here. I want to mention I've been around this field for 6 years now, and Devin and Shoshana and CMAT has been probably the only organization that I actually noticed that they deeply cared about the role of lived experience and they actually lead from that place, as you all just heard. It's very rare actually for medical professionals to actually talk about their own lived experience. It's courageous and I honor that. And I actually think it makes people be able to relate to them more. So thank you for doing that. Yeah, maybe we go to the next slide so I can dive deep a little bit into why lived experience matters. But essentially, the idea here is that generally there is an emphasis on medical expertise and therapies and and they hopefully have their own lived experience, a lot of them, which is what gets them to come to this work, right? But at times when they're wearing that hat, they can't really see certain things because they can't be in two places at the same time, right? So even if they had their own lived experience that led them to this work, while they're at work, someone like Devin is probably going to be a doctor hat on, right? So it's hard in the moment to see what someone else might be seeing, right? And that's, I think, where if you could see it as like a Venn diagram where you have like maybe medical and scientific expertise on one side, then you got therapy, and then you got lived experience. And it's really when they come together that actually magic can happen, right? Because when individuals go through these very subjective, intensive experiences, they have this sort of embodied knowledge, right? It's like what I call healing wisdom that really comes from being there and allows you to see both yourself and the condition beyond the sort of clinical assumptions that perhaps exist part of your story, right? And then they also bring this critical perspectives, right? They can actually help you see risk and nuance harms and certain blind spots, like I was mentioning, that is much harder to see for other professionals in the field. And there's a lot of like patient-centered care slogans you hear out there, and everyone talks about it, but honestly the only way to really do it if you actually do embed lived experience across your model, right? So like there's someone like that maybe in your team, and if you're making all sorts of decisions about your therapy model and all that, you make sure that you run that through someone with this experience, hopefully like a councils of them and multiple people, because at times people might have healing experiences, they might have harmful experiences, they might have some so-so or meh experiences. Those are all real, right? And it's only if we start listening to people that we could actually see what's happening, because mainly in this field and like any other clinical research, there is a basically the only thing that matters is quantitative data, because that's what FDAs and Health Canada's are required. They don't actually require qualitative data, but by itself is not really the full picture, right? So if you're only looking at published data, if you're only looking at people as like numbers on a spreadsheet or charts, we're not really seeing everything else behind it. As actually I was listening to Devin talking about chronic pain and the sort of biopsychosocial model, I was like, oh, I wonder if you could see PTSD in a way as a chronic pain in the psyche, right? Maybe that should also be looked at through that lens of biopsychosocial. Another thing that I want to say, I noticed that CMAT does differently. That is during the screening process, you're already looking at these sort of social environmental factors that honestly, even within clinical trials, they're not doing that. Another thing that I believe CMAT is doing differently, right? At times the screening is about someone's medical history and, more like the the individual, but not so much of like what's around them and the environment they're living in. And I'm really inspired to see that as part of this screening, because these experiences are very subjective, they're very intense. At times you might feel like you go to hell and heaven and everything in between, right? And it's really hard to understand that and put that into papers unless you start actually talking to people. And most people might have actually different experiences, right? As we know, like not all trauma is the same, not all PTSD is the same. And then I want to touch on a few other things that I felt through my own experience. Maybe we go to the next slide and I can share a bit more of my personal story. So 6 years ago, I learned about MAPS and MDMA therapy for PTSD. And there was a site back in Montreal, Canada, when they were looking for a single participant back then in 2008 across all of Canada. There was one site. They were looking for one participant for the therapists to be able to then finish their experiential training so that they could go on and work on phase three. So they needed to conduct one experiential case. So they were just looking for one. I guess lucky me, I was chosen as the one, and I went through that experience 6 years ago. And in the most cliche way, I would say it really did change my life, and it gave me a whole new way of looking at through my suffering. I would say it didn't cure my PTSD, but it forever changed the way I look at my PTSD, and to me, that's cure. It was my outlook on it. The way I looked at it was permanently changed, right? That doesn't mean like, oh, my symptoms immediately went away, which they all did eventually, but it was really the outlook, the way I looked at it. And I think that's only possible through this model where you're still doing intensive therapy with someone, but you're doing that under the influence of such medicine, which then allows the individual to actually get in touch with those parts of themselves safely. Because obviously they feel safe in the first place, which is what caused them the PTSD. And for them to go there, they need to be able to do that safely, right? Which is why other models at times don't work. So what's really novel about this approach is that you're still doing intensive therapy, but you're not doing it at the cost of maybe causing harm to the individual by exposing them too much when they're not feeling safe. And I think that's very revolutionary, and that's probably why the FDAs of the world are struggling with to even how to make sense of it. It's very cutting edge, and I'm more than happy to obviously share more of my own experience in the Q&A if people have more specific questions. But something that I've noticed in the last 6 years that I've been in this field now is that I realized we just need to bring more attention to the stories of people, those that have been through the experience, like someone who's had PTSD, someone who's had chronic pain, someone who's gone through the medical system and figured something, maybe they try different medications. Like it's a whole world there that unfortunately we're not really looking into unless we actually start caring about people with lived experience, bringing them into a decision-making process and making sure that the models and the treatments that we're creating are actually serving people and not just look good on paper or maybe makes money, but not is actually helping people. Um, those are the things I wanted to mention. I'm happy to be here. And yeah, maybe we'll go to the next slide, then I can share a bit more about what I've been working on. Like I said, I noticed going to conferences and trainings and everywhere else as you go, there's always a lot of therapists, doctors, researchers talking about this work, but there was like a real lack of people with lived experience presenting themselves and their stories and lessons learned. And then I realized that actually the main issue in this field was that we needed more bridges between these individuals, right? So like we need the doctors, we need the researchers, we need the therapists, we need these experts, but we also need people with lived experience. And it's only when all of us can actually work together, kind of like what we're trying to do here at CMAT, is that really magic can happen. So I decided to organize a summit, which is happening in November 21 to 23, and it will be 50 plus speakers over 3 days with 3,000 attendees. You'll have a chance to actually listen to at least 27 people who've been through different psychedelic experiences, different treatments for various different conditions. But you also be able to learn from seasoned clinicians, experts, right? As we have here, like Devin and Shoshana, who are both part of the summit. We'll be exploring ethics, safety, real world impacts, and yeah, lots of things to learn from the whole experience of conducting clinical trials, going through clinical trials, receiving these treatments, and so much more, which you can find on psychedelicexperiences.com/summit, and register is free to access. And there will be lots to learn there. So I'm excited to work on that. And I think that's for me. More than happy to continue in the Q&A though.
Thank you so much, Pedram. I'm just both Devin and I will be participating in the Psychedelic Lived Experiences Summit, and it's just such a joy to be entering into these conversations and really kind of yeah, laying down some of the framework for shaping some of this vision creatively together as to what is possible going forward. And especially during a time of so much profound and significant change in this field that is as it is growing and evolving. And so bringing these voices and these experiences just feels like a really essential part of that. And so hearing these stories and hearing the real life impact really helps to kind of illuminate some of the realities of what is happening within this field and how it is impacting the real lives of people who have experienced harms, who have experienced challenges, who have experienced traumas, and what that can look like um, in real time, in the way that that can profoundly shape lives, including all three of us here this evening. So yeah, thank you so much. And it touches near and dear to my heart, as you both know. So I'm going to be speaking a little bit about what it looks like to be accessing medicine-assisted therapy at the Center for Medicine-Assisted Therapy. And we're located in downtown Vancouver. We have an extensive website, which will be sharing details at the end of how you can stay in touch with both Pedram, Devin, and I, get more information about the Psychedelic Lived Experiences Summit, as well as the services that we offer at CMAT. And so, yeah, this is really a new paradigm for modern medicine. When Devin contacted me and kind of we came together with a small group of very like-minded individuals to really creatively vision what it might be like to bring to life a clinic that is offering something like this in a new way. Values aligned based in clinical research with medicine best practices, a clinic of excellence. our hearts were what we brought forward in really being able to look at saying, okay, hey, we are a group of doctors, we are a group of therapists, we bring our skills, we bring our all of our expertise, but more than that, who are we? What do we bring to this? What are the experiences that we've had in our own, um, pains and traumas and things that we've healed through? What have been some of the challenges in these spaces that we've encountered? How do we want to actually realistically look at this and shine a light on some of the things that maybe aren't working in other spaces, some of the gaps that are in other spaces, some of the things that maybe other spaces aren't willing to talk about or look at? That's very much been how we've been engaging in really rich and inspiring conversations with Pedram in relation to lived experiences. And what does that look like in real time in terms of bringing that forward within the community, with really deep roots in terms of our values and our heart? So, Center for Medicine Assisted Therapy opened in January of 2025. We have two clinical rooms we call the Garden and Grove, and we really have brought a lot of knowledge and expertise into how we have shaped the process for clients who are looking to be able to explore if medicine assisted therapy is the right fit for them, and also for doctors and practitioners to be able to refer clients. And those are some of our treatment pathways, referral pathways. And so, what that looks like, I'll speak a little bit more now. Thank you, Devin. Is accessing medicine assisted therapy at CMAT. So, there are two pathways for that, two primary pathways. Is that if a practitioner that you're working with is wanting to, feels that you may be, meet the criteria or may benefit from exploring if medicine assisted therapy is the right fit for you, we have an interdisciplinary and collaborative team at CMAT that can really support that process and exploring that further. And that is approached with a lot of care and a lot of support. And so a practitioner can refer a client to CMAT via our website. And then we have a suitability questionnaire that a client can fill out directly, or a practitioner can directly fax a referral form. And for clients, we do have a get started link on our website, and that will give all of the information very clearly in a step-by-step process as to how you can take the next steps in exploring if medicine assisted therapy is the right fit for you. And so we support clients from start to all the way through our treatment protocols and beyond. And so we really bring a lot of care and intentionality into how we've shaped this intake process. And what that starts with is a free 30-minute information call with Dr. Devin Christie, who is CMAT's medical director, and an opportunity to be able to ask some questions, bring some information as to what you're healing through, really learn more about this process towards determining together if that is something that you can explore in the next steps. We have a lot of detailed information on our website about what that looks like. And so obviously, if you're wanting to have a better understanding of the full process, you can always email me as well. And there's lots of information on our website. And so one thing to highlight is that medicine assisted therapy is currently private pay. We do hold a vision where that may continue to change in the future. And for right now, there is limited third-party liability insurance coverage depending on what a person's specific plan is, if they have one. And that may possibly cover something like the preparation sessions or integration sessions, which are therapeutically based. And our treatment model is right up front. It's very clear at CMAT. And so the cost of treatment is between $300 and $355 per therapist treatment hour. That depends on the mode of administration at this time in terms of which medicine you're doing, and also some of the variables, which include, for example, like Devin was mentioning earlier, that for certain medicines that are accessed through the Special Access Program, we do offer a co-therapy model, which includes two therapists. And for ketamine assisted therapy, we have a one therapist to client ratio, but we also have a collaborative care team that's part of each unique client's experience. Thank you. So we have allocated a lot of spaciousness for Q&A. We've got some questions there in the question and answer section. Please, by all means, anyone who is joining in today, we would welcome for you to be able to put your questions in there, and I'll be kind of moderating with Pedram and Devin, bringing your questions forward and having a space to answer them. And in real time, you can add questions if something is inspiring you, something you wanting to hear more about that's already been discussed. And also, as I mentioned, that you you can get in contact with us. We are very much interested in being able to continue this conversation. And so we've included here how to connect with us on social media, how to connect with us on our websites, and also our emails that are included for CMAT. And we really just welcome this space of engagement, this space of education, this space of self-inquiry, and also just the ability for us to kind of gather in together and extend the reach of our voices and our care for this field and the significant impact that this work can have on many people's healing journeys. And before we move into Q&A, Pedram and Devin, is there any final thoughts prior to kind of engaging in some of the questions that our participants are asking?
I think I'm happy to move into Q&A. Yeah.
Awesome. Okay, great. So one of the first questions was just in relation to if we'd be sharing the slides, and I'll answer that one directly. So basically, we have recorded this webinar, and we will be uploading that online, and we will be sharing that link in a future CMAT, an upcoming CMAT newsletter, which will give you the opportunity to be able to watch the recorded webinar. And so one of our first questions here is that we have a question here from one of the participants who's asking how many therapy hours. This was in relation to when you were discussing, Devin, the MDMA assisted therapy.
Okay, great. Yeah. So at CMAT, we have two options. We offer the full MAPS therapeutic treatment protocol. And there are some changes that we've made based on my experience as a therapist in the research study and sort of observing what was maybe optimal or suboptimal or things I would have liked to have been able to change in the protocol if I could. Of course, when you're in a research study setting, you cannot change the protocol. Everybody has to follow it. So we are following it in terms of the co-therapy team, so two therapists. And we are following it with 3 preparatory sessions at a minimum before the first MDMA session, followed by 3 integration sessions, and then the second MDMA session. And then what we also offer for people to do 2 MDMA sessions, not the full 3. So in the MAPS research, the phase 3 studies were 3 MDMA sessions, but in some of the phase 2 trials, they also had 2 MDMA sessions as an option. So it's certainly also a cost consideration because this is expensive therapy. I mean, there's no way around that. There's 2 therapists, and not everybody may necessarily be able to afford to have the full 3 MDMA sessions, but could certainly still benefit from having 2. So that's one place where we could do 2 MDMA sessions instead of 3. The other place that there's some cost savings for people accessing care is that our preparatory and integration sessions, whereas in the research protocol they were 90 minutes long, they are 75 minutes. So that does, like, over the course of the 3 prep, 3 initial integration, then the next 3 integration, and if we're doing 3 MDMA sessions, an additional 3, so a total of 9. That does also save a fair amount of time each time. So the total hours, I think if you look, it is on our website. So if you navigate to our website to what we offer, our services, you'll be able to see we've sort of categorized out treatment hours in these 4 categories: seed, sprout, sapling, and tree. So seed being really the number of therapeutic hours for an individual to do 1 ketamine session with the necessary preparation and integration, whereas the MDMA therapy that we offer falls into the tree category because it is the most intensive, it is the most therapeutic hours. So the exact number of hours are going to be listed there, or the approximate. But as I mentioned earlier, in the research study, the protocol was 52 hours. I believe that ours is closer to 46 for the whole therapeutic protocol, with the time that we've kind of shaved off a little bit there. Yeah, so thank you for the question.
Thank you so much, Devin. So we've got a question here regarding, can you say a little bit more, and this could be for either yourself or Pedram, about some of the other modalities besides psychotherapy?
Well, I think I want to maybe understand that question a little better because I think, when we say psychotherapy, we're using it as a very generic term. Like within the umbrella term of psychotherapy, there could be many different modalities. So, the modalities that we practice that are holding and supporting the medicine assisted therapy at CMAT, part of our unique approach that is very, very important for us is all of our therapists are trained in relational somatic therapy. So, somatic therapy is a trauma specific therapy. And you might have heard of somatic experiencing or sensory motor psychotherapy. These are very, adjacent modalities to relational somatic therapy. And so that is a key foundation of our therapeutic approach and the modality under the umbrella of psychotherapy that we bring forward. And as I mentioned, also, we all have level one internal family systems therapy training, which really informs the psychodynamic, the psychodynamic framing that we bring. So we bring what IFS brings forward, which is this kind of understanding or referencing this natural kind of multiplicity of self that is part of just healthy human beings that kind of can be reflective and reflected in parts language like, oh, there's a part of me that wants to eat that cake and there's another part of me that would feel really guilty about it, right? Like we use that in our language very commonly. Parts approach with IFS is much more nuanced and there's a real process to it. So we layer that framing on. We love it because it's non-pathologizing and it's really about understanding and getting to know all our parts, the ones that are trying to protect us and defend us, and the ones that are holding on to all kinds of burdens of suffering that the protectors are trying to keep at bay, and really so that the whole system can have greater harmony. And even though talking about parts might sound complex, really in practice, it really simplifies. All the feedback I always get from my clients is it's really simplified their self-understanding and brought a lot of organization to it and relatability to it. So those are our modalities of psychotherapy that we pair with medicine. Of course, we also bring the MAPS therapy, which is very much congruent with this for MDMA, which is considered an inner-directed approach. And these modalities that I just named, IFS and relational somatic therapy, are likewise inner directed, meaning that we are recognizing the client is the expert of their experience, and how we hold that and how we show up and the questions that we ask are going to help that client to expand and deepen their experience and their self understanding. We're not going to just practice talk therapy or insert our own analysis about the person for them. We want to help the person explore the totality of their experience, which is very much enhanced under psychedelic medicines, so that they can make the meaning for themselves. So I hope that answers the question. Really, other modalities to treat PTSD or chronic pain could be many. I mean, I could list many, but really the focus of this today is the medicine assisted therapy.
Thank you so much, Devin.
Do you want me to add a little bit from?
Oh, please,
Yeah, I could
please.
actually say, I would
Yeah.
say perhaps within the MDMA assisted therapy protocol, what does make it very special is that it gives sense of control and agency back to the individual. And as trauma survivors, you probably lost that during the trauma, right? Something happened that you lost your sense of agency and control. And this treatment is actually trying to give you that back by putting you in charge of your own healing, right? So, if anything, perhaps it's a positive thing that the team you're working with are not coming through like, here's how we've always treated PTSD, and we're just gonna do X, Y, Z to you. And it's just not like that. They're actually gonna sit there and see what comes to the surface for you, right? So, and I would actually say one thing that CMAT is doing differently, perhaps, is this sort of focus on somatic, the sort of body keeps this score, is actually something that I would say it's the MAPS protocol could improve upon. And it looks like that's what you've done, Devin, based on your experience, that you've noticed that probably, right? Because you can't just talk about your things. At times, it's just beyond talking and it's in your body. And unless you have a therapist that understands that, then you won't be able to let it out safely. So yeah, I just wanted to say how empowering that actually is to allow the individual to be in charge of their own healing, and they might come to this I speak to many people, for example, some military and veterans, a lot of them that end up with PTSD, they think that it was something that happened during their service, and vast majority of them, by the time they do this um, sort of treatments, they realize that it was something way before that, like something to do with their childhood, something that were, much younger. So they go in thinking, here's my trauma, here's what I actually want to heal. But because this treatment allows them to then whatever comes to the surface is allowed, right? And then if something shows up that happened when they were 6 years old, well, now the treatment becomes about that, not like, hey, but that's not why you started this. We're just gonna go keep focusing on that other thing that you said, right? So this just really puts the individual back in the driver's seat, which is by self-healing.
Yeah, thank you so much for adding that. It's really powerful hearing that perspective, like coming from you, having gone through the treatment and how and just describing it from your lens. So thank you. I did think of something else. I don't see any immediate questions in the question box, but I did think of something else to add to our conversation because Pedram, when you mentioned like maybe PTSD is kind of like the chronic pain of I forget the exact words you
I
used.
said the psyche, chronic pain
Of the
of the
cranium of the
psyche.
psyche. Well, yeah, and so that I didn't put this detail into this talk for tonight because I didn't want to get too scientific and jargony, but um, I did an extensive look at the literature and the science and the neuroscience of chronic pain and PTSD and found so many papers that describe chronic pain and PTSD as reciprocal, interdependent conditions. We do know that there is a huge amount of comorbidity, which is the medical term for these two conditions happen in the same person at once, both PTSD and chronic pain. It's such a high rate of comorbidity, higher than really any other, I think, conditions out there. It's huge. And part of why I dug so deep into the literature on the two conditions is because I learned that MAPS collected accessory data on chronic pain in their phase 2 studies. And I actually got permission to access that data because I wanted to know, well, what happened to the pain, right? Because the primary endpoint of the study was the CAPS-5 score and the PTSD symptoms. And so I worked with a statistician and some others, and we did the analysis, and we found out that 85% of the study sample also had chronic pain. And when we separated it out into high, medium, and low chronic pain intensity and pain related disability, the people in the medium and the high category, which was the majority of the people with chronic pain in the study, had significantly improved chronic pain intensity and disability related scores at the end of their PTSD treatment with MDMA, which was amazing. So chronic pain got better as a side effect of the PTSD treatment in this sample. It was I think 38 participants. If you're interested in learning about that more, I would direct people. We published this in an open source journal, Frontiers in Psychiatry. So if you just Google like my name, like Devin Christie, chronic pain, PTSD, you'll find it. It'll pop up. And it was exciting. It was the first paper to be published showing this positive association in chronic pain. And I'm now becoming involved with a study team who's actually been awarded a Canadian Institute for Health Research, CIHR, grant for studying MDMA for chronic neuropathic pain. So first of all, it's exciting because the Canadian government gave a $1 million grant for this study, which I think is really groundbreaking here in Canada. There hasn't been much public funding for psychedelic treatment really at all. This is very new for these conditions. And yeah, I'm really excited to kind of continue that line of inquiry to see if really MDMA assisted therapy may also be a breakthrough treatment potentially for chronic pain as well. And I think there's a lot of rationale for that. So yeah, I want to just come back to that.
Lovely, thank you. So we've got a bunch of questions here in the Q&A section now. And so
Great.
we've got one here that's asking about, does dosage depend on the client or is it standard across sessions?
It definitely depends on the client. So we start out in ketamine. We start out with a sublingual plus or minus supplemental intranasal dosage of ketamine in the first session, partly because the onset is a little slower and more gentle with these modes of delivery. And then we observe how profound the person's response is to that dose. So we would call it a mild to moderate dose. And then some people respond quite profoundly. And we're like, okay, they're sensitive to ketamine. And then we would do dosage adjustments and even change method of delivery according to how the person responds. So it's an individualized thing. Ketamine intramuscular is dosed milligrams per kilogram, but different people have different metabolism, different other sensitivities. So we really want to observe that and we really tailor it to the person.
Thank you. And so we've got a question here that's asking specifically in relation to someone that may be pursuing the medically assisted death due to chronic pain, for example. And they're wondering approximately how long the intake process may take, and to the time that med sessions may happen.
Yes, absolutely. As people who have applied to MAID are clearly experiencing deep suffering. And we absolutely want to support that person's journey, even if they continue on to MAID, right? Absolutely. We believe that healing can happen into death. You know, healing is not just synonymous with curing some physical ailment. Healing is a full total person thing, mind, body, and spirit. And we absolutely want to support people who are pursuing MAID, who have maybe end of life anxiety or distress, people with a terminal diagnosis who often pursue MAID. We absolutely want to make our services available. In terms of time to treatment, it's currently within, I would say, uh, 3 weeks, 3 to 4 weeks. Shoshana, would you say that's, yeah, is about how quickly we could, once, we could certainly do an intake probably next week, but just getting everything set up with the therapist and everything scheduled out can take a little bit of time, as well as doing the suitability screening and just making sure it's safe.
Yeah, definitely. I'll add just a little bit there. So, um, as the clinic director at CMAT, I'm really mindful about a supported onboarding process. There's a lot of requirements in terms of the way that we have shaped the clinic, but the reality is that this is a very specialized and unique kind of route to treatment that is not yet as mainstream as we may hope in the future. And so, with that, we have on an onboarding process that is quite robust, and do need to ensure that we are bringing clients on board safely and effectively, and we do need to gather a lot of information for that to happen. And so, with active client engagement in a way that feels accessible to your own body, your own nervous system, your own lived experience, we do offer kind of two routes for onboarding. One route is kind of self-directed, where you are engaging with me kind of by email or by text or by phone, and you will be kind of actively pursuing the various steps to scheduling in online on our online booking system and also filling out the online onboarding questionnaires that are required for the clinic. The other option for that is a supported one-to-one onboarding process. And what that looks like is that, we recognize that everybody's body, every nervous system, every brain is capable of different amounts of information on the onset. And so we don't want to kind of be bombarding people with an overwhelming process when people are already going through an already often overwhelming lived experience. And so what that looks like is that we want to make sure that we are approaching this mindfully in a way that fits what's right for you. And so if that means that you're located in Vancouver and you are physically coming into the clinic, we are sitting down together in a kind of a therapeutic onboarding process. That is also something that I am offering within the clinic space as well, and that is also helpful to kind of break down some of the barriers towards making the onboarding process be as supported and as smooth as possible, and also making it more accessible for people who may, not have a lot of familiarity with an online space, may not have, technological wherewithal, may just need some additional support for their own system. And so that is an option as well. And so as I'm looking here through some of the questions, so we do have a question here that is regarding um, there some additional details that a participant is asking around how is CMAT different from other clinics that are already established, for example, like Field Trip, and is there an emphasis to decolonize some of the work? A lot of this work has now been colonized and exploited by clinics, and is there something that our clinic is specifically focusing on or has a focus on?
Do you want to speak to that, show, or should I jump in?
You can start and I'll join in. I'm
Sure.
just going to kind of review the other questions just to make
Yeah.
sure we can
Yeah,
get.
sounds good. I mean, first and foremost, I would love to refer people to a talk I just gave, which really is a whole hour devoted to really this question with the Embody Lab. I was just part of their free online somatic psychedelic summit. And my topic was on um, improving the ethical approach to delivering medicine-assisted therapies. And what I was talking about was the approach we use at CMAT, which is these 5 invitations that support therapeutic processing that keeps the person centered as the expert of their experience. And that really resists colonizing minds, right? Like we're talking about the ethics of this work are very, very critical. And that's something that I think probably differentiates us. I mean, I teach in many different psychedelic therapist training schools, specifically on ethics and on somatic modalities and why they're ethical in this work. And that was the focus of my talk at Embody Lab. But so to summarize a little bit there, people are in highly vulnerable states when they take medicines like this that are psychoactive. And one thing we know is that it can increase suggestibility. And so there's already a power dynamic in any relationship where a person is seeking care from another person, right? It's vulnerable to seek care. There's something that that person is bringing forward, and then the person they're seeking care from has some kind of knowledge or expertise or something that qualifies them to be a person that supports that person's healing process. And therein is already a power dynamic. And it's important that we name these dynamics because if we don't, that's when trespasses can occur and people can be harmed intentionally or unintentionally. We believe in right use of power. So, what that means is knowing this power dynamic and upholding right use of power, meaning that I know that as a clinician, I have certain responsibilities and certain expertise that it's my responsibility to bring forward to support a person's safety. And also, in naming that there is a power dynamic, there's also my responsibility to support the empowerment of the person that I'm working with. And when we talk about suggestible states under psychedelics, um, if I wasn't conscious of the critical ethics here, then I might unintentionally, when a person's in an open state of consciousness, start to tell them my opinions, start to share my own worldviews and impose them, while a person's in a wide open state, potentially having a very profound experience that my lack of awareness around my responsibilities to make sure that this remains focused about them and their own worldview and their meaning making process, I could seriously cause comment and almost colonize that person with my own whatever. We don't do that. We do not do that at CMAT. We're very, very passionate about that. And the somatic therapies, as I go into more detail about in my presentation as well, are specifically designed to be embodiment oriented. They are about lived experience and being curious about that person's lived experience and the wisdom that comes from that person's lived experience and their ancestry and their history. And so we're about supporting and learning and listening and helping a person really ground themselves in that and bring that through in their own healing process, as opposed to imposing this kind of healing modality onto a person that they have to kind of like go through this protocolized thing that's cookie cutter or whatever that isn't sort of putting them at the center and supporting that through really engaged, embodied investigation, language, and relationship building. So those are some of the ways that we really differentiate, I believe, ourselves in this space at CMAT because of our training and background and the expertise that we share in the broader community.
Thank you, Devin. And what I'll add to that is also I think what differentiates CMAT in a number of ways, especially from in terms of the first part of the question from other clinics or other models, is that, the reality is that most medically based models currently are lacking an emphasis on preparation and on integration. And so it's one thing to be able to go to a space where you can access medicine assisted therapy, where you can access psychedelic or altered states of consciousness in the service of the hopeful outcome of healing. However, if you are void of a really solid preparation process where we can try our best to ensure that there are just not really any surprises. You have a sense of what you're going into because you have a solid foundation of really what it's going to look like, what your intentions are, what the setting will be, what our approach is, what the sessions will look like, that you have a voice in that, that we can push pause at any time and we can reassess, that we can reevaluate, and that what actually is breathed through that is your own voice. This client-centered approach where self-empowerment, where this inner healer, this inner wisdom, this inner guidance is not imparted onto you by us, that our skills will be supporting the room, that our therapeutic expertise, our knowledge will be within the space to support your inner guided process. And that is paramount. That essentially we are not guiding you anywhere. We are supporting you and we are right there with you. We will be with you in the midst of the deepest parts of your experience. And the reality of that is through that comes a space where, in a lot of spaces, there's this emphasis on the trauma, which is the reality of many of the lives, the expressions of what is happening in this world right now and our histories. However, there is also, I think, sometimes there's this kind of space where we're not talking about the potential for healing. That, when trauma is happening too fast and too soon, you're missing time, you're missing the space for your body to actually be able to feel through, to shake off, to express through it what needs to actually be felt in service of your own healing potential. And so, what that looks like with an emphasis on some decolonization is very much around this kind of breaking down some of the hierarchical structures, that we're not on a pedestal above you as therapist or doctor, where we're, like, as Devin's mentioning, we're not looking down upon someone and saying we know what's best for you. We trust that actually you know what's best for you, and we are there alongside to be able to help encourage the possibility of the most optimal outcome, about the possibility of healing potential. But that really is very much something that comes from the inside out. And so, and Pedram and I have talked a lot about this as well when we were both in Denver a few months ago at the Psychedelic Science Conference, is how can we really start to look at like how we are stretching some of the edges of these systems. For me, that's very much based in a background of social health and equity advocacy, really recognizing the importance of voices being extended in this space, really focused on recognizing some of the social determinants of health and what that means in real time in these spaces, in an educational space, as looking at curriculum, in research spaces, looking at the medical professionals that are part of these research studies, how they can extend the voices of real people and their lived experience. The work that Pedram's doing in terms of how lived experience expertise can be brought into the kind of collaboration that we are shaping at CMAT, how it can be brought into spaces that are informing the education for practitioners. And so we are actively excited about community-based projects and opportunities for us to engage in that way. And part of that is really trying to light up the part that is inspired in each of you, in ourselves as well, about like what can we do in real time to be able to bring that to life. So yeah, thank you for that question. And I can feel my these are the kinds of questions that to me just are such a beautiful reminder of the possibility and the potential that exists in how we can be an active part of kind of shepherding the path in a way that feels that brings on board a lot of the things that we've learned from, and a lot of the things that have been challenges in the past towards a brighter future.
Yeah,
So
and can I say one more thing, just very briefly, to bring clarity to this question? It's such an important question. It's like we walk a very fine line, right? Because we're attempting to legitimize therapies in the dominant healthcare system, which is colonial, which is a system of oppression, really. I mean, the amount of patients who I see as a physician who have been seriously harmed and oppressed in the system of medicine is huge, especially working in chronic pain. And so some of the concrete things that we're trying to like birth something that is still supported by the dominant system, but helps to transform the dominant system by how we're doing it, right? To be the seed of it within the system, but to change the system, which is really the whole goal of my career as an MD, why I even got those letters. Um, to be in the system and change it. But like the core things here is our non-pathologizing approach. Like we still kind of will operate in the system that uses terms like PTSD and depression and personality disorders and stuff, but we don't necessarily see people as those conditions, right? Which is what happens in Western medicine. We see people as people. Those conditions are labels that can be helpful and harmful, but we don't ultimately see people as pathology. We see them as whole people in a journey here. And then I think the other sort of piece of clarity too is one of the main things that distinguishes like Western versus indigenous systems of knowledge is that Western systems of knowledge are rooted in rationalism, right? Whereas indigenous systems of knowledge are rooted in embodied wisdom, right? And that's like what we are really talking about. Like our therapies are really emphasizing embodied wisdom and not like this rational approach of physician knows best or therapist knows best and I'm going to tell you my analysis of you. No. So that's another sort of core thing. So yeah.
Thank you, Devin. So I
Oh,
just
we're
want
at the end of our time. Oh my gosh.
we're at the end of our time. We do have three more questions that are in the queue, and but I just want to, in service of time, just acknowledge first and foremost, thank you so much for everyone that has attended this evening. If you're wanting to stay on for a couple of more minutes, that is an option to be able to answer briefly the remaining questions. However, we also just want to make sure that we are acknowledging and honoring the time container that we've set for this webinar this evening, and just acknowledge that we really look forward to staying engaged in whatever way that looks like for you. Again, we have shared ways to be able to keep in touch if you have additional questions or you want to engage in some of learning more about that, about CMAT and also about psychedelic lived experiences, that you can take a look at our websites where there is a lot of helpful and detailed information. Also, in terms of registering for the Psychedelic Lived Experiences Summit through the link that Pedram has shared, and that we're looking forward to be able to hearing the voices in real time of so many significant people who have gone through clinical trials and also who have shared their voices in a variety of spaces, as well as medical professionals, doctors, nurses, therapists, and just a wealth of individuals that will be bringing their voices to this space. And so if you do need to log off, we want to thank you. Thank you for taking the time to be with us this evening. Thank you for taking the time to learn more about these offerings and about these spaces that we are so very proud to be in. And if you do have a few extra minutes or your question hasn't been answered, Pedram and Devin, if you do have a couple of extra minutes, we will stay on and answer those questions briefly. And again, this is the first webinar that CMAT and Psychedelic Lived Experiences with Pedram Dara that we've offered, and it certainly will not be the last. So we will look forward to continuing to be engaged in a community-based level, engaged in education, research, as the weeks and months proceed, and we will definitely be sharing opportunities to lean back into the conversation again. So I will just go quickly to the remaining questions here, Devin and Pedram. So one question here is specifically in relation to the discussion around the chronic pain treatment and how during the ketamine treatment that ketamine as an avenue for reducing pain. We have a participant who's asking how long does the effect potentially last? And also any idea of like how much the ketamine affects the duration will affect one's perception of, yeah, but up with bodywork therapies. Yeah. So just
Yeah.
about some
Yeah, I
kind of
can jump in. I mean, it's interesting. Most research out there shows that the analgesic effect of ketamine can last beyond 48 hours, sometimes up to weeks. So it's within, days to weeks and even months. That's been reported in the literature. So it's going to be case by case, of course, individualized. But we've seen windows of sort of a reduction in pain effect from a single dose of ketamine or from a series of ketamine infusions or doses of ketamine that can last for a significant amount of time.
Thank you. And then we've got a question here around, can you talk to the actual risk on incidence of cystitis
Yeah.
with
So
regular ketamine use?
most of the literature that has shown this risk with ketamine of bladder irritation, which is cystitis, is coming from people who've been using ketamine recreationally and obtaining ketamine that's been cooked in, not pharmaceutical grade laboratories, more street ketamine. However, there have been a couple of publications that do explain somewhat of a mechanism by which ketamine may be causing bladder irritation. So it's seen very, very infrequently, actually, in medical settings, and pretty much reported in the literature through non-medical or recreational use. So I would say the risk is low, but it's going to depend on a person's use. And often in the more recreational setting, when people have addiction or substance use issues with ketamine, which do exist, they're using multiple doses per day, a lot of ketamine. And that may also be part of why it may accumulate and start to cause irritation to the bladder.
Thank you. And so we've got a question here that's just kind of elaborating on the question previously that was posed surrounding the modalities. And so just to kind of clarify, this participant is a board certified body worker in the United States, and they're kind of wondering around non-talk modalities like working on chronic pain. Where is the physical medicine scope of practice integrating with the collaborative care team?
Yeah, this is a really great and cool edge of this kind of more recent explosion of interest in psychedelics for treating chronic pain. And like, how do we design these interventions? If people have like these windows of plasticity or like critical period plasticity opened up by these medicines that can last for days or weeks, how can we optimally integrate physical modalities like physiotherapy, like body work, and all these things into a treatment protocol that's biopsychosocial for a person with chronic pain? And I want to highlight that, this is what we're exploring and doing at CMAT. We are launching a chronic pain specific program where we are really focusing on delivering the medicine and the psychotherapeutic support, but also encouraging people coming through that program to, in tandem, work with physical therapists, body workers, while they're in that period of the protocol so that we can really synergize these different modalities together. Just even thinking about like complex regional pain syndrome or phantom limb syndrome, right, where people are doing already things like mirror box therapy for their phantom limb. Well, how might that be potentiated when a person has had some psychedelic on board that may enhance plasticity and enhance learning and support that, even just like that as a simple example of a physical modality for pain that may come in an integrative, truly collaborative model that involves these medicines. So I think much to be learned, much to be explored and researched. And yeah, theoretically, really, I mean, it makes a lot of sense to come from this multimodal approach to benefit from that.
Thank you so much, Devin, and such great questions to our
Yeah.
participants. Thank you so much, and thank you so much to our hosts this evening. It's just been such an enriching conversation, and just yeah, I just feel my heart just feels so full in terms of just looking forward and being excited to continue to engage in these discussions together. Any final words, Pedram or Devin, before we wrap up the webinar this evening?
I mean, I could just share how refreshing it is to actually have a team that is not so corporate and trying to scale things up and all that. Because speaking of what makes it different, I think that's what it is, right? Like it's very different to work with a team that's there, it's like a going to a boutique versus going to like a franchise fast food. right? They're not the same experience. You might get food, but it's not the same experience. So
Yeah.
that's the only
Thank
thing I
you,
want to mention.
Pedram. I want to shout out to Adrienne Marie Brown. Some of you out there may know her, but she talks about emergence and emergent phenomena. She wrote a book called Emergent Strategy, like understanding that life is all these open systems, complex systems, ecosystems that we're embedded in and we are. And one of her core principles of emergent strategy is that small is all. And so that's part of how our ethos at CMAT is that we're doing something really, really good on a small scale so that that can organically inform and spread and connect with different nodes and be something really, really beneficial. That's our hope. Yeah. Thank you so much. It's been a joy being on this with both of you tonight.
Thank you so
Yeah.
much. And if there are any questions that we haven't addressed, we will definitely take a look at them and we will be following up. We have CMAT newsletters, we have blogs that are actively engaging in content that is in real time, following for extending the reach of these conversations as well. And so we definitely encourage you to take a look on both of the websites of CMAT as well as Psychedelic Lived Experience for learning more information. And we will be gathering back in again in the future. So thank you to everyone who's joined this evening. Thank you both to Pedram and Devin, and we look forward to seeing you in person at CMAT, to seeing you online potentially at the Psychedelic Lived Experiences Summit, and to gathering back in for future webinars and community-based offerings.
Thank you so much. Good night,
Thank
Thank
everyone.
you. It's been a
you.
pleasure.
Bye.